Great. And word on the street is Chris is an engaging ethics speaker, which is really huge. I know sometimes that can be a tough topic. Chris, you're muted if you wanted to chat, just FYI.
Thank you. No, ethics is definitely one of those topics where you sort of need to bring it to life, you know, so I hope to do that.
Good, good. The pressure's on. And I see some of our Breakfast Club sponsors are on the call too. Hi, team.
Hey, everybody.
Hello.
Hey, Megan, nice bit on the Grizzlies. I appreciate that as a hockey player.
Oh, you are welcome. It was actually really fun to do that. So
Next time I want to see skates and some pads on out there, a little more interactive.
I know. I thought of trying to do that, but maybe next time.
I actually play in the league there. It's a great rink.
Nice.
I definitely feel like I'm missing out on something out here.
Yeah, so Megan posted an awesome video of her interview. So Megan, take it away.
Oh, so I just went and interviewed the athletic trainer for the Utah Grizzlies.
Oh, wow.
They just celebrated like their 25th year anniversary here in Utah, and Rocky Mountain has been there from the beginning with them. So we've been their physical therapist since day one. So just kind of did a little interview at the hockey rink. So it was kind of fun.
Oh, that's awesome.
And
Is that
without
a local
therapist, we couldn't continue to play hockey. Trust me. I got an appointment in a couple more days.
Nice.
I was playing a little middle-aged guy basketball not long ago, and I definitely needed some PT after that. So I hear that.
It's the mind fooling the body.
Right. Well, we'll see where I end up next. Maybe it'll be the gymnastics meet and I can, you know, swing on some bars or something.
I used to be a high school gymnastics coach, just so you know. So
Oh, there you go.
be out there.
I can come practice with you before I go.
Okay, I'll spot you. All right, I know we want to get started at the top of the hour, so we'll get started here in just a minute or two, just because obviously, you know, with back-to-back speakers, I want to be cognizant of everyone's time.
So I just want to, just really quick, nobody has to show their face. Nobody wants to, it looks like, but I'm going to be writing down everybody that's attending. So if your name is not really your name, I will not know that it's you to give you your CE credits. So if it does not say your name, so I know, because I'm just going to take roll so I can make sure everybody gets their credits.
And we'll also be, Chris will be asking a couple of questions throughout his presentation. So make sure that you are responding to those, because that will count for the CEU credit as well.
Yeah.
All right, since we have housekeeping items and I have a little bit of an intro, is everybody ready to rock and roll?
Yeah, let's get going.
Awesome, thank you. All right. So Chris, whenever you're ready, you can share your screen when we transition out here, but welcome everybody that's joining. I know we've got a little over 30 folks on the call right now. Hopefully a couple more will trickle in. Like I said earlier, we have two great speakers. We have Chris Schaub, and we also have Spencer French. So he will be after that. Did I say your last name right?
You did. That's why I was excited. I was a little celebration there. Sorry.
It's only because I called Ann right before, so I cheated.
No, you did your homework. There's no cheating in that. Well done.
There you go. Okay, perfect. So a little bit about Chris is he has worked in brain injury post-acute since 1995. And his focus has been on neurobehavioral programming for individuals at all levels of the spectrum of where they need support. And, you know, depending on what their impairment is. He does have a master's in behavioral analysis from Temple University. He's been board certified in behavioral analysis since 2004. And he, has been working with ReMed in partnership with Learning Services in the neurobehavioral and rehab services, as well as our supported living programs. And so this is short-term and long-term supported help with any complex neurobehavioral needs. He does consult with our behavioral analysts on all of our sites. And he's presented at numerous conferences in these fields of brain injury and behavioral analysis. And like I said, I've heard that he is an engaging ethics speaker, which is just great. He has published several articles on the topic, and he is part of our ethics committee to make sure that the unique needs of our clients are being taken into account, and everything is going well with their unique circumstances. So with that, Chris, I'm going to turn it over to you. And then just so you know, just a quick reminder, there will be a Q&A in addition to a couple questions Chris will be asking at the end, and I'll be reading those off, so he can take care of those for you.
Danielle, I just need someone, the host, to allow screen sharing for me. That's all.
Oh yeah, sorry about that.
Perfect.
No worries.
Megan's going to do that for you right now.
That's an easy fix.
Yes, it is.
And as Danielle said, I'll just sort of start talking because that's something I'm known to do quite a bit of. And I'm hoping really to breathe some life into these ethical principles, which we'll review from the standpoint of case management per the audience, but also understanding that each one of us as a clinician, for example, as a behavior analyst, we have our own set of a code of conduct for behavior analysts that's quite extensive relative to the work we do with folks as behavior analysts. So we all have our own frames of reference that we're working from here. And what I want to do is just go over those briefly. I'm still waiting for the screen share, Danielle or Megan. Yeah, but anyhow, that's okay. I'll keep talking. Just, give me a thumbs up when you're ready. And so what I hope to do is, certainly because it's an ethics talk, I want to make sure that I show a slide that has the code, the ethical principles on it with some definitions for our reference. But then I really want to move into, because that creates like sort of a boundary and parameters for us to work within, right? And keeps us sensitive to the kinds of things we need to be, especially working in the complex world of post-acute brain injury.
Excuse me, Chris?
And so, oh, yes, sir.
Oh, can you co-host now? Can you get on?
Yes, I can. Thank you.
Thank you.
Thanks.
Oh, that's not it. That's not the one.
I was like, we see it though, Chris.
You guys can see it?
Yeah.
Oh, okay. Okay, that's interesting. Good. Okay, great. So anyhow, we all have our own codes of conduct and relative to ethics, and we need to be certainly aware of those and adhering to those in an ongoing way. But what we really also need to do is we're responsible as clinicians to, there we go. We're responsible as individuals, as a collective group of clinicians, to establish practices and philosophies within that code that meet that code of conduct, the expectations and the requirements therein, but really then also drive the programming and the treatment that we provide to our folks with traumatic brain injuries. And as Danielle alluded to, the bulk of my experience has been in intensive neurobehavioral, which, as anyone that's been working with brain injury for a number of years knows, can really be quite varied in its complexity and sort of the amount or array of sort of sequelae or residuals from a brain injury that you're helping someone work through, or helping their family or caregivers work through as well. So as I said, I want to get into the case management code of conduct, so I can say that I sort of included that and touched on that. It's also going to be relevant for the, sorry, hang on one second, guys. Something that happened with my screen share. Get my talk back up here. Get rid of that.
Gotta love technology.
Yeah, right. Let me reload one more time here.
Sounds good. Yeah, because the screen wasn't advancing.
Yeah, I noticed that too. That was a problem. Now, where are you guys? Here you are. Screen share.
We did get a comment that folks really like your backdrop.
Oh, so I'm in Pennsylvania right now, and I live near what's called Longwood Gardens. So that's a beautiful place if anybody's ever out this way to visit. And shoot, I would highly recommend putting it on your list. It's tulip season right now there. So why am I not getting my screen share now? There we go. Oh, no, sorry. Or hang on one second here, guys. It's not giving me my full screen here. Not sure why. Everybody, for some reason, it's not showing me my options to share screen right now. Oh, shoot. Sorry, guys. Up there it is.
I'm just thinking I could pull it up too. Let me look.
I think I might have it here.
Okay.
Next, I was going to say, I think I have it too, because I had to give it to the state. So if we need to help you, we can try out either way.
Let me try real quick here. All right.
Is it able to advance? Because we see the main screen.
Get back in here.
See the
Oh, there we
next
go.
slide.
Okay, there we go. Everybody good? Okay.
Yep.
All right. Well, that's going to make my mission of delivering an ambitious talk even a little more challenging, but that's okay. No worries. So as I said, I want to make sure to kind of touch on as sort of the opener for this on the ethical principles. And these come from the world of case management. And so, things like, and we all have our own relative to our particular disciplines, code of conduct as well. But for the purposes of this morning, we're looking at the code of conduct for case managers. So autonomy, beneficence, non-malfeasance, justice, and veracity are all of the things that are related to the, sort of represent the code of conduct or the ethical principles for case managers. And those involve things like respecting one another's right to self-determination, right, and independent decision-making. Beneficence is about compassion in what we do, which brain injury, and especially working with intensive neurobehavioral folks, or even folks on the mild to moderate side, which if those of you that have been working, there's really nothing mild or moderate about a brain injury, right? Require a lot of compassion from us. There's also a lot of circumstances that are very, very challenging, and we have to make sure that we're refraining from doing harm to others, and we're focused on quality outcomes. And then on the justice side, we want to deliver the best care we can to everyone in a fair and equal way. And then veracity, we want to be honest and upfront with the information that we provide to all stakeholders. Certainly first and foremost the individual and the survivor, but all the stakeholders involved, whether that be their spouses or their children or their immediate family or their friends, and absolutely on the other side of including the insurance case managers that are involved in these cases, the adjusters and the external case managers, and the variety of folks that we interact with. We have to make sure that we're representing everything in an honest and true way. So what I'd like to do is move from this foundation of these ethical principles to introduce our neurobehavioral philosophy. Because as I said, the ethical principles create parameters for us to work within, but they don't provide us with a philosophy. And I've spent the 25 years I've been at Remed, being a part of the development of this philosophy that I think is important to share right now. And so in our work with neurobehavioral folks, intensive, complex neurobehavioral folks, we've come to establish this neurobehavioral philosophy. And we've written about it, we've talked about it. There's a reference at the bottom there to an article that we wrote about it several years ago. But it's really sort of at the forefront of everything that we do. And as much as it's a framework that we use on a per case basis, it becomes highly individualized. It really becomes kind of a structure or an outline that we fill in on a per case basis, depending upon what that individual is bringing to the table or what they've sustained as a result of their injury in terms of deficits or residuals, as I mentioned. And at the top, you'll see it says establish medical stability. And as a behavior analyst, I can say that medical stability has everything to do with learning capacity. So if you can imagine some of the folks that you might be involved with or work with who have issues with pain or sleep, or their medications are, being changed or maybe not well managed, or if not effectively managed, or maybe being managed by a variety of providers. Maybe there's a pain specialist that's involved, and maybe there's a primary care physician. There may or may not be a physiatrist. There, even more rarely, there's a neuropsychiatrist involved in care. And so all of those things, medications and sleep and pain, vestibular disorders, which is something that we've really had to become fluent with and aware of, all of those things can affect what we call medical stability, which from my perspective, affect an individual's learning capacity. So therefore, the degree to which someone is or isn't medically stable is going to really guide the kind of work that we do from the outset. Because our goal is to then establish behavior stability and cognitive enhancement through, skill building and introducing tools and techniques, and then ultimately reestablish a stable activity plan for folks. But without medical stability, that's a really difficult process. And I hope that the cases that I, described today, there's 2 cases to review. I really hope that they help illustrate how we enacted this philosophy within the parameters of the ethical principles, if you will. So obviously, as a behavior analyst, I'm in that left-hand corner of that promoting behavior stability. That's a key part of my job. But everything we do at ReMed is interdisciplinary. So in this intensive neurobehavioral settings and otherwise at ReMed and Learning Services, we have the full complement of rehab teams. We have OTs and PTs and speech therapists and therapeutic rec specialists, psychologists, drug and alcohol counselors, neuropsychologists, behavior analysts. And then we have our medical consultants, right? We have physiatrists, as I mentioned, and psychiatrists and urologists and pulmonologists and a whole array of people depending upon what an individual's needs are. And that really requires us to do a number of things. Number one, we have to prioritize needs because time is always an issue or is often an issue. And then we have to integrate those efforts. So not only do they need to be prioritized, like what comes first, second, third, but then they need to be integrated in an ongoing way. And we've arrived at this philosophy that really helps us to do that. And I also have to say, for many, many years of my work at ReMed, I was involved in early meetings with families as folks were being admitted. And there's almost an indelible image of this pyramid or triangle on the whiteboard in our conference room back at the One Campus, because we would use this as a way to take a family who had been through this traumatic and tragic experience and try to help organize and break down what's going on for them and try to give them a vision, if you will, of how the process is going to proceed. And sometimes we would only play a role in that for a certain period of time because of circumstances. And so what we would do is we'd enact this plan and this philosophy, but we'd also then, write it out for them and give them recommendations to follow this in an ongoing way. So even if we didn't get to sort of from beginning to end of treatment with someone for a variety of reasons, we sort of felt a real obligation to have folks leave with kind of a book, if you will, about what to do, kind of a roadmap, so that when they go and see other specialists or interact with other caregivers, they have some like a map or a compass to use to guide their efforts and understand what needs to be involved. And so this is the way in which we've presented that and use this to educate funders and also organize and integrate our comprehensive interdisciplinary team. Now, this is all well and good. It all makes sense. It's been a good standard of practice of ours for many, many years. But one of the things we know that affects especially how people interact from an ethical standpoint, I think, is awareness. And what I want to talk briefly about in terms of awareness is how that relates to behavior change and how that, sort of guides our interventions in terms of an individual's ability to self-manage, because oftentimes in an intensive neurobehavioral environments, we have folks who can be very discontrolled. That can look like sort of the stereotypic version of behavior, like aggressive or threatening or demanding or eloping or engaging in some other kind of high-risk behavior. But as a behavior analyst, to me, everything's behavior. So that's a category of behavior, but we also have folks that are really confused or disoriented, maybe a persistent or chronic sort of a PTA state. We have other individuals who, have profound deficits and they're more on the inert side and they're hard to engage or hard to get to initiate activities. So all of those things for me fit in within this definition of behavior. But what really, we learn about as a key feature of folks' success in rehab and afterwards in terms of brain injury is the level of awareness that they develop. And so in the 80s, there was a lot of research coming out about awareness. It really got identified as a hallmark trait of brain injuries, particularly when the injuries involve the frontal lobes, right? And so Crossan, you'll see the reference at the bottom, and his group, and then others, George Prigatano, that followed, did a lot of work in the 80s around awareness. And they identified this awareness pyramid, which I have represented here in this arc or arrow. And so awareness really can drive a lot of features of treatment in brain injury. To the extent that someone is or isn't aware, really guides how the team is going to engage or intervene. And so it's key that we understand this to some extent, right? And so at the very top of this pyramid, Crossan and others identified this level called anticipatory awareness, which means that not only is someone aware that they have an injury and they're aware that it affects them in the moment, but then they're able to engage and plan based on that. And so therefore they can anticipate where they may encounter difficulties due to their brain injury, and they can act accordingly. In the middle there is something called emergent, which is someone who is aware or identifies that they have a brain injury. And they're able to understand in the moment when it's affecting them, but they can't make that leap to anticipate the next time. And then there's folks sort of in this intellectual level, which are simply able to say, I was in an accident, I have a brain injury, but they can't really think beyond that in terms of how that affects them in a moment, and certainly aren't at the level where they can anticipate how that might affect them going forward in the future or in other kinds of situations. And so as a treatment team and as a behavior analyst, we've had to kind of really understand this. And what we've mapped onto this is this model of self-management. So what you'll see, say at the bottom, for example, with intellectual awareness, someone who's only able to identify that they have a brain injury needs a lot of help in different parts of their day. And so we adopt a sort of a treatment model of follow our lead. Let's walk through this. Let's prepare the situation. Let's prescribe, for example, a PACE. We've treated and admitted lots of folks with significant pain issues that can disrupt their sleep, or they have vestibular issues, as I mentioned before, which is kind of that inner ear and balance and proprioceptive and sensory input system that's critical for movement and vision and auditory input and all those kinds of things. And photosensitivities can come from that. And so when folks come in and they're profoundly affected by that, they might only be able to say, wow, this really hurts, but they don't understand what all of that means, or I feel like I'm going to fall over, or I can't last that long in session. So the follow my lead version of that is we prescribe a PACE for people. We prescribe breaks. We understand, and we take breaks ahead of time before they're in sort of a crisis mode. So, and that's in the beginning. And then we ultimately want to try to teach those kinds of strategies as someone becomes more aware of the features of their brain injury. We start to introduce rules and routines and rhythms and try to arrive at this co-management model, where they understand and appreciate they have an injury in the moments it's happening or affecting them most, they're able to identify it. And from that comes a level of awareness that creates receptivity to these rules and routines and rhythms. So we've maybe been the ones in the beginning that have prescribed a certain set of medications or a certain activity rhythm or certain even structure for sessions. But now we're actually working with the person to begin to employ some of those things on their own. And so we sort of call that this co-management model when we're in this emergent stage of awareness. And then ultimately anticipatory awareness, not only does the individual sort of understand what's happening, that they've had a brain injury, how that affects them in the moment, but now they're using the plan that we've co-authored, in the moment, maybe during a trial in the community, or maybe during a trial of a home visit, for example. So this awareness model, I think, is really relevant in terms of ethics, because some of the most high-risk behaviors happen when people have the most severely affected impaired awareness. And again, for those of you that have been working in brain injury, it can be someone who's physically capable. It can be someone who's got good cognition, relatively speaking, but they might have this profound awareness deficit. And that's potentially the primary issue that's causing problem behavior in the community or at home in relations with a spouse. There are a number of men my age, so to speak, that I can count off of one hand that over the years never got back home, ultimately, or it was difficult to get back home because of their awareness deficit and how persistent that was. So I just wanted to put this out there because, again, as treatment teams and as members of treatment teams, however that may be the case, we do need to take into account these awareness issues and what effect they're going to have on changing an individual's behavior. And I hope that the case studies I present are going to help to kind of like flesh that out a little further in terms of how you go about changing behavior, relative to someone's level of awareness, and how that then interacts with the ethical principles that we talked about in the beginning. So for case one, a woman named Sarah who she was diagnosed with MS in 1988. So she did not have, quote unquote, a traumatic brain injury. She had an acquired brain injury due to the progression of her MS. Now, the interesting thing about Sarah is she had lived in the community for 25 years and raised a son who coincidentally graduated from high school while she was living with us and while she was admitted to our program, rather. And we had a whole effort to get her there to see her son graduate. It was somewhat local. Our clinical director went, our OT went, because she was still not terribly stable at that point. So there was a level of risk involved, but we really felt it was important to have her there for this moment, which we all felt was quite powerful. But unfortunately for Sarah, her MS had progressed and there were significant changes in cognition and functional status, memory impairment, confusion, awareness deficits, and ultimately high-risk behaviors. She was falling at home. She was agitated. She was paranoid. She had, her son at one point, even in the end of his high school time, had moved in with a friend's family because things had gotten kind of rocky with his mom. And she was just under the care of, home health aides that were coming in to help her. And she was accusing them of stealing things. She was calling her family repeatedly. She had elderly parents who were in the area who ultimately had to move away near one of their other children because there was so much pressure coming from Sarah that it was affecting their health, quite honestly. She was calling 911, demanding that they come and help her get off the ground. She had fallen at one point prior to coming in, I think 150 times she had called 911 in 1 month. And so you can imagine the sort of pressure that puts on the community. She was psychiatrically admitted in 2013 and then transferred to an acute rehab facility where her behaviors continued to escalate, including eloping in a power wheelchair, which is a especially challenging sort of situation to manage if anyone's ever been in one of those situations. Ultimately, Sarah was, admitted to ReMed in 2014 for neurobehavioral rehabilitation. So she presented with a lot of complex needs, and also someone who had been dynamically independent for, 2+ decades, and was really severely impaired in terms of awareness. So her son lived local, and initially his involvement was problematic. He was reacting strongly to his mom's concerns, as any of us would, and oftentimes he could be quite contentious. So we had to really think about how to educate him and bring him into this, this larger understanding on behalf of his mom. Fortunately, there was a longstanding third-party guardian in place. I know guardianship is a key issue, especially in intensive neurobehavioral work. The immediate family was involved from a distance. As I mentioned, she had a sister and brother, I think in Texas and New York, respectively. But the current providers, guardian, and siblings were in support of her referral. The only one not in support of her referral and admission was Sarah. This is a woman who had a master's degree from the University of Pennsylvania in social work. So she was a pretty seasoned gal relative to rights and advocacy. And we really respected that, but she really did not understand why this was necessary. She put a lot of the blame for her situation on her caregivers at home, on the community, how it had let her down. People had misunderstood her needs. And so it was really pretty profound, her level of awareness impairment. And interestingly, through her funding sources, there was a nursing home that would have been available, but the medical and behavior instability absolutely precluded her candidacy for those settings. So she was kind of stuck at home until, fortunately, one of the people involved in her care mentioned ReMed, and we were able to facilitate an admission. But she came in the door significantly upset and provoked. And so, again, just to kind of reiterate and reemphasize this model that I reviewed previously, this is almost an exercise we would do in the room with the team. And that is, we would use this sort of triangle, and we'd start, as I mentioned, mapping around that all the different areas that we know or understand to require attention and care or needed to be assessed or addressed. And then we start wrapping around that the different specialty areas or disciplines that are involved in that kind of care. Now, we do this implicitly at this point and kind of move and groove, if you will, in that kind of way. But this is really sometimes very helpful for families to understand the array of things that are going on, how we're going to kind of get it all in one big plan, and how we're going to start to, prioritize and integrate our treatment in those different areas. And so, as I mentioned, we have a full complement of an interdisciplinary team. Plus, we have this, model of kind of case manager as the hub of the wheel, and they're helping to interact with these external folks, whether it be our, urologists or neurologists. We're fortunate we have a lot of in-house nursing, and especially in our, medically complex or intensive neurobehavioral programs. And we have a physiatrist as our medical director, and we have a long-standing relationship with our neuropsychiatrist. So we're routinely involved on a weekly basis, as a matter of fact, with our physiatrist and neuropsychiatrist to kind of make sure that we're, coordinating our care with them, and they're giving us their recommendations and prescriptions, and we're following up with data and analysis of those data for their benefit to make decisions about, the next level of care. And then we have the complement of the interdisciplinary team to work in the other areas that are around those bottom corners of this triangle. So as you can see, Sarah had a lot going on. There were a lot of competing issues, and there were also a lot of folks involved in her care. So what I want to move to next, because I'm a behavior analyst and I'm a little bit of a nerd this way, I'm going to show some data. But before I do that, I just want to prep everybody. This is data about Sarah's behavior when she came in the door. The graph I'll show will have data on medical instability. It'll have data on the number of requests and attempts and crisis. Let me talk about what requests and attempts are really quickly. When Sarah came in the door, she had been, again, a fiercely independent woman with MS for 25 years. So she was used to self-impacting and self-cathing herself in order to, maintain her bowel and bladder continence. And she was also someone who was really, really worried about hydration to the detriment of her own health at times, because she was worried about having accidents. And so when she came in the door, there were frequent requests from Sarah to toilet. So when she would request a toilet, we would just admitted her. So we were endorsing those or complying with those requests and taking her in there. She would sit on the toilet and begin to try to self disimpact or self catheterize. And we found that those methods were problematic. She seemed unsafe. She was rocking around a lot. Fortunately, there weren't any falls because we had staff in there with her. But as you can see, there were a lot of requests. So the requests in those black dots are referencing on that far right axis. So we're, sometimes as high as 16 or 18 requests per line. And her attempts were actually when she would, in her own power chair, wheel herself right into the bathroom to go, if it were unlocked or if it were opened rather, and someone weren't in there, she would roll right in and try to put herself on the toilet, which of course was a high risk situation. And so that represented a level of crisis for us. And crisis otherwise was defined as she would call 911. There were a couple of occasions where we had her say in a standing frame early on, and she had a cell phone that she had access to, and I'd be in the program, and all of a sudden the police would roll up, and they'd come to the door and say they got a call for 911, and we were all sort of unaware about what was happening. And here Sarah had called from her standing frame to tell the police that she was being neglected and abused. And so of course they show up as they should, and we have a discussion with them about the situation and resolve the issue. And typically on they went, and we would reassure them, and we would call her family and guardian and make sure everybody was aware of the situation. But it was really, really challenging as Sarah was coming in the door, making a lot of requests. And then on that, if you'll see those red dots where they're labeled as mood instability, reference that left-hand axis, because some of those rates of that were, as you can see, those axes are double one another. The mood instability goes up to 40, and the requests, attempts, and crises only goes to 20, because there were significant amount of mood instability coming in the door. And mood instability was defined as tearfulness and disruption to the milieu or a group activity or a meal due to verbal upset. And these were really intense emotional episodes that she was having. Now, if you'll notice in looking at the graph, there's a lot of black dots and lines, but nothing else. It's not too busy on the first half of the graph. And there's a reason for that, as any behavior analyst would want to know. Because what we eventually had to do, due to the dysregulation and unpredictability and variability in her self-cathing and self-disimpacting, we needed to establish a schedule for that so we could support it, keep it safe, keep her from harming herself potentially with too frequent of attempts. But when we instituted that structure or schedule, Sarah was highly provoked. And that's why you see the kind of follow after that line of those episodes of attempts, and also the emergence of that mood instability. So she became highly emotional about this. She became very upset. She wasn't aware, didn't understand or appreciate why any of this was necessary. But we were following the wisdom and expertise of our physiatrists, our urologists, our rehab nursing team. We're all really heavily involved in the introduction and the development of this schedule. But we knew as a neurobehavioral program, it was going to provoke quite a bit of behavior, which it did. Now, one of the things we saw with this mood instability for Sarah and her sensitivities was we were talking with our physicians, and our neuropsychiatrist was discussing the mood lability, which he really felt strongly was a feature of her MS that would be appropriately treated with a medication. Now, when we started that conversation with Sarah, it was a non-starter. She was adamant that she didn't need any medications. She had been fine on her own, and thank you very much, she didn't want anything that we had to offer. So we knew that that was going to make our work difficult, or more difficult perhaps, and certainly more difficult for Sarah. But we made the decision not to, make it necessary, which we typically don't do, right? This is a whole process of getting to know somebody, developing a relationship with someone, and trying wherever possible to promote awareness so we can get to a point of collaboration in the treatment plan. So our team, all the way through certainly the direct care staff first and foremost, we're enduring quite a bit of behavior after we introduced this schedule. So as you can see in the subsequent month, this behavior kind of carried forward. There's more triangles, so there's more crises. The requests are somewhat down, which is good, but that was replaced with a little more crises and more mood instability in the middle. The interesting thing, since we weren't going to go the route of medical stability right out of the gate, we knew that was going to make it difficult for us to introduce behavior programming, but we didn't think that based on our assessments from speech and neuropsychology, we didn't think that would be impossible with Sarah, because she did have, as I said, she was a master's prepared, social worker. So she had pretty good, prowess from the standpoint of cognition. And we thought, well, let's try to engage with her, because she was also really upset that she had been brought into a residential setting and no longer had the community available. She had actually been driving for most of that time that she was living in the community as well. So we began to talk about the possibility of introducing some behavior programming. And what that looked like was, as a behavior analyst, I had to be really sensitive, and our team needs to be, about how much we can sort of expect from the standpoint of behavior criteria and how reasonable and achievable that's going to be for the individual that we're treating. And so for Sarah, we knew that if we targeted all of these behaviors, it would be an unsuccessful and an unrealistic plan. But what we were really concerned about were the attempts in crisis. We were really concerned about the crisis behavior for her safety and the safety of others. And we were certainly really worried about the attempts she was making, meaning like her attempts to self-toilet herself, as being highly unsafe. So we targeted those two behaviors. And what we said to Sarah was, if it can be safer, we can start to re-enter the community at some level. And that at some level looked like even a trip to the park or a ride in the van. And that ride in the van or trip to the park was done by myself or a very select group of 1 or 2 or 3 other designated staff that would be able to handle a crisis if it in fact occurred in the community, because we still knew there was a level of instability present. But we wanted to try some behavior programming to see if we could get a hold of some of these behaviors and help Sarah kind of calm down and begin to respond to some of our efforts. And so here's what happened. So what you'll see is in this month after we introduced the behavior program is we got a reduction in crises. There's only one on the 21st and at the very end of the month. So and on the 9th, there are a few episodes of crisis, but much fewer than before. The requests were down. We were sort of redirecting requests, right? So Sarah was beginning to learn that her requests were going to be redirected to the schedule and that we would support her to toilet at that schedule. And you'll see there was only one attempt outside the schedule during that month. So what these data suggested to us was, even with a level of medical instability that we were concerned about, Sarah was still able to engage in effectively behavior programming. And so we were moving ahead thinking, okay, we got a handle on crisis. We got a handle on these attempts. We're moving in the right direction. Moving on into August, a lot of those behaviors are almost absent. However, Sarah was still experiencing a lot of mood instability. So she was happier that she was in the community more. We expanded that list slightly, but not so much, because there was still a lot of mood instability going on. And what I was actually able to do was sit with Sarah with these data and talk with her in a very direct and honest way about her progress and where she was in her treatment plan. And what I said to her, we were, educating her about, she had made progress, she'd been more in the community, but really this mood instability piece was preventing us from advancing her community access even more so. And she was really, I actually showed her these data and sat with her and looked at them and met her where she was sort of, from an intellectual standpoint, and really engaged with her. And so what that resulted in was an agreement that she would start Risperdal just a little bit. She met with our neuropsychiatrist. A number of us met and educated her about that. We felt like we had better control over, or better stability in her behavior, that is. But this mood stability piece was just going to continue to kind of prevent her from progressing ultimately to more access and greater levels of sustained stability. And so we introduced the Risperdal. And there was, this is like Memorial Day, or Labor Day rather. It was a holiday thing around visitation, so that got kind of wonky. But if you continue past that into September, you'll see there's a lot of days with no behaviors or no upset. There's much better control over upset as you go through the month with those red dots. And as promised to Sarah, what that meant was we were able to introduce a greater level of community access. So that meant she was a devoted swimmer. So we got her into an adaptive swimming program. She really wanted to go back to her hairdresser. So we were able to do those kinds of things, and her family was able to engage with her in the community more so. And that was just a terrific outcome. So, we initially really felt like the Risperdal would have been good out of the gate. I think it would have really helped things from the outset. I think we would all agree about that clinically at the program. But we also knew from Sarah's standpoint and her perspective, that would have been a non-starter and probably would have prevented us from any future collaboration, or at least any in the near future collaborations in her early part of her admission. So instead, we started targeting these community outings, the modest ones in the beginning, helped her with that and developed some contingencies, and she was responding to those, and that was good. But there were these persisting mood instability features, and eventually she was able to review the data and have a more thoughtful conversation. She never changed her mind. We sort of agreed to disagree, but we did agree about the Risperdal, which, as you can see, really helped stabilize her mood and mood lability, and allowed us to open up the community in a more expanded way. And so, from our standpoint, that was a really terrific outcome, and I think a nice way to demonstrate some sensitivity to these ethical principles that we're talking about this morning. So, knowledge check here. Which of the 5 ethical principles is highlighted? And you can use the chat feature at the bottom of your screen there. If you hover down, there's a bar that'll pop up. It'll say chat. And you can just, if you can't see that, you might have to click on the 3 dots for more, but chat's there. If you just take a second and, go to the chat menu and go ahead and, input an answer. And again, the point about this is highlighting the decision-making process for Sarah regarding the introduction of the medication. We held off on that and didn't do that until a later point in time. And so from our standpoint, I think what that really highlights is we respected Sarah's autonomy. We respected her right to self-determination. We knew that she was, again, adamant about not needing medications or wanting medications at the outset, and that would have really affected our relationship and would have affected her treatment plan and progress from the day of admission or soon thereafter. So instead, we were capable within our environment of managing her behavior, while those was clinically involved, developed some early behavior programming elements that Sarah was able to respond to. Now, had she not responded to that, we probably would have been in a different problem-solving mode. But fortunately, we moved ahead with the behavior programming, had some success with that, and then we're able to kind of engage with Sarah at a different level around the particular mood instability piece. Okay, so case study number 2. And I'll apologize in advance. These slides are even a little busier with text. And as my line for that is, it's really hard to represent someone's life on a slide. When you're talking about the folks that are like people in these slides, or like some of the really complex folks that we all work with, it's an impossible task to have to somehow put all that onto the screen so someone can kind of get the whole story. So I did my best. It's a little dense, but I really felt compelled to include some key details about Sarah and Fred. So for Fred, Fred's a more recent injury, and Fred was actually injured in a truck accident at work. He was a truck driver at a coal plant. He was actually the safety manager at the coal plant. The truck he was driving, the triaxle truck, was coming down the hill towards the coal plant, and the brakes failed. And Fred had a decision either to just keep going and careen into the workspace where all of his coworkers were and buildings were, which this truck would have done significant damage, maybe even would have been fatal. Fred rolled the truck off the road that he was on. And that truck rolled a couple of times, and he had a brief loss of consciousness. So he got rolled around in the cab of this truck. The records that we had suggested there were several episodes of loss of consciousness, all less than 5 minutes. Head and neck pain, and he was combative in the ER. And this may, I mean, it's a pretty all too unfortunately common story from my perspective, maybe from yours as well. But Fred was diagnosed with post-concussive syndrome and sent home the following day. Severe pain, vision, vestibular, sleep, mood, fatigue, almost immediately upon return home, which incidentally was a remote location in West Virginia with very limited services. I mean, outpatient that Fred was provided following his injury was a 1-hour trip one way. So treatment efforts were unsuccessful due to complications. He couldn't endure the car rides. When he got there, he was overwhelmed. He was shut down. He was in pain. He was agitated. He was shutting down at home. He wasn't engaging with anybody at home. He had vision disruption and significant headaches that were debilitating. And that was contributing to ongoing disruption at home or discontrol. He was falling. He wasn't sleeping well. And all while this is happening, keep in mind, because of the kind of limited services, not only were they an hour away, but they were only focused on pain. So it was a pretty significantly limited treatment plan. It wasn't comprehensive or integrated in any of the kind of ways that I've mentioned previously. And so the initial referral was actually made to ReMed's Maryland-based program because of proximity and geography. We thought that might be, more friendly in terms of Fred and his family. However, when we did the intake with Fred, we realized there were far too many issues, and they were too complex and unstable for that to be the appropriate place to admit Fred. So he was referred to our program in Philadelphia. So the complications with Fred. So initially, the initial admission date with Fred was postponed because Fred called and said he fell and hurt his wrist and couldn't come. And that very well may have happened, but we absolutely took that as a hint that Fred didn't want to come. And I think the second bullet sort of underscores that. So he admitted several weeks later, but from what we heard, that was only after he had a conversation with his, I guess it was his workers' comp representation, that his benefits might be in jeopardy if he was unwilling to seek appropriate treatment. So Fred, it was 6 hours to get to our program from West Virginia. He came in the door and said, "I'm not interested." And that was about all he said. And then he went to his room. For the rest of that day and evening, he refused food, drink, meds, and all attempts to interact or engage. So it was a really rough day for Fred. Not only did he not want to come in the first place, but the 6-hour car ride absolutely overwhelmed him and provoked all of his symptoms, likely in the most severe kind of ways. And so he came in really agitated, and we just sort of let him settle in and kind of kept an eye out and tried to keep him safe and wait and see what happens the following day. Well, the next day, upset, refusal, and demands persisted, despite all of our efforts to try to engage and encourage. And he began calling his wife and case manager. So Fred, I was actually at that program. I had some interns. We have interns from Temple University, and I was meeting with them, and I got a call from someone in the house that Fred was out in the driveway attempting to elope. So I obviously abruptly left this meeting, ran out of the driveway and started talking to Fred, and Fred was making a lot of aggressive statements towards me, a lot of threats towards me to get out of his way. He was walking towards the road, and ReMed uses something called Crisis Prevention Institute, Nonviolent Crisis Intervention. And I happen to be one of the trainers for ReMed. So I was employing all of our nonviolent crisis techniques to try to verbally de-escalate Fred. But ultimately, it required me to physically prevent him from stepping onto the road. And he took a couple swings at me, and I had to turn him around and and I kept saying to him, "Fred, I'm just going to stay in here. I can't let you on the road, but you can kind of wander around and roam around back there. There's plenty of room." Which he eventually did, but then he picked up his call and picked up his phone and started making calls to his family saying, "When I get home, I'm going to kill you." It was really upset with his wife. He homicidally threatened his case manager. So we were talking with his wife and the case manager throughout this in the background while I'm in the driveway. There's other members of the team in the program talking to these folks. And the decision was made to call 911 due to safety. Fred was unwilling to come back in the program. He was refusing medications. He was attempting to leave in a terribly unsafe way. And it seemed unsafe to support him to return home because he was making these threats of harm to his wife and case manager. So the police arrived, and with their involvement, Fred agreed to go to the hospital. Unfortunately, when Fred got to the hospital, that didn't help him calm down. He became combative, was physically restrained, and he was 302'd. So unable to find a bed for crisis. I'm not sure how many folks in the audience have been involved in 302s, and I know that's maybe Pennsylvania specific nomenclature, but that's an involuntary admission. And then usually at the ER, they're looking for a bed at a crisis center or at a behavioral health center, and there weren't any beds available. So Fred was in the ER. So Fred's sitting in the ER, he's agitated, he's restrained, and that's not the best place for him to be. It was the safest place, but he's not getting great brain injury care there. And that's not a site on the hospital. That's just not what they do. They're not a brain injury rehab facility. They're a hospital, and they were doing everything they could to keep Fred safe. So while Fred was in the hospital, we were still collaborating with his case manager, his wife, and the hospital, of course, after the 302. Discussions between Re-Med and the hospital resulted in the start of Depakote. We actually pulled our neuropsychiatrist in, who was able to speak with the attending physician at the hospital. There was a recommendation for Depakote. And Fred was ultimately there, I think, about 3 or 4 days, which allowed the Depakote to begin to kind of do its thing. So while in the hospital, Fred was speaking with his wife, his case manager, his social worker, the doctors, and Re-Med, all of whom in chorus were recommending he go to Re-Med to get help. So 4 days later, Fred came back to Re-Med, stable, open, and remorseful. Now, the remorseful part's only important because Fred was able to reflect on how unsafe things had become, how upset he had gotten, how overwhelmed he was, how in pain he was. He started to comment. I mean, I saw him, and I was the one in the driveway physically preventing him from leaving. And I thought, I wonder how this is going to affect our working relationship. But when he came back from the hospital and I saw him for the first time, he came right over to me and apologized and shook my hand. I said, Fred, we're here to help. I can promise you it's nothing personal, and I'm glad you're here. So we really sort of made Fred feel assured Fred that there was truly, we weren't judging anything. We weren't, taking anything personal, holding anything against him. We understand that this is just an unfortunate part of this process for some folks. And we knew we could help Fred. So we really focused on, let's get you help. And then here's how, once again, this model of neurobehavioral philosophy and programming, here's how we mapped it all out. Fred had fatigue, vestibular, there were medications that needed to be adjusted. There was pain, there was sleep, vision impairment, there were headaches. His cognition was severely exacerbated. The symptoms, rather, were severely exacerbated by his symptoms. His cognition was overwhelmed, and he couldn't problem solve or think. He would shut down. He'd become demanding. All of these things. He was distrusting. Even though he was back, he was still a little bit distrusting, a little bit isolative. So we had, our team members, neuropsychology and psych and behavior analysis in there. And we know these other features of his stable activity plan had just completely deteriorated at home. And even that said, even at his best, Fred was going to be more limited in that regard. So this is a map of sort of what it looked like coming in, but this is where we start to work and tinker and develop programming to address these things so that Fred can return home more medically stable, more stable from a behavior standpoint, with an understanding of his cognitive deficits and how his physical and medical symptoms will affect those. And then ultimately using all that information to help Fred re-envision a life back at home, which we knew wasn't going to include an immediate return to work. But he had grandkids living in the house with him. I think one of his children lived there. It was her kids. And so Fred was first and foremost wanting to get back to his family. And then from there, he really wanted some guidance about what else would be safe for him to do. So, this whole plan started to take hold and progress. And so this diagram sort of demonstrates that progression, right? So we didn't have the same kind of data from Sarah. It was a slightly different case. But here's how I want to sort of portray this. So from a medical standpoint, we did comprehensive evaluations, pain, vision, vestibular. And because that medical stability is at that apex of that triangle, that guided the progression of the treatment plan. Medication adjustments and modalities to address pain helped diminish his pain and improve his sleep because it was less disrupted by pain. Treatment for vision and vestibular issues resulted in prism glasses and a reduction in those symptoms. So all of a sudden, Fred's system is less under attack. Fred's feeling more calm and more stable for longer periods over the day. So that allows us to move into testing, right? So initially the focus was on stabilization of symptoms and less on engagement. We needed Fred to kind of just be engaged to get better in the vestibular areas or managing his pain. The rest we knew for the moment was kind of off the table. But as those symptoms decreased, we got testing done. We educated Fred. We educated his family and his funder. We began to introduce self-management techniques for pacing and coping. and recovery. So we were obviously teaching Fred to prevent symptoms, but at the onset of symptoms, we taught Fred to manage those and how to recover from those. And then ultimately strategies followed for Fred to manage information, time, and tasks, all which were, affected by his cognitive residuals as well as his medical and physical residuals. And on the stable activity plan side, on admit, the community access was limited and breaks and rests were prescribed, as I mentioned previously. But as the symptoms were resolving and decreasing, self-management of pacing, coping, and recovering was increased. And that allowed us to introduce community trials across settings and activities, which for Fred led to more insights, right? Because you have this kind of sterile environment of a residential, or can feel sterile of a residential setting. And folks can kind of dismiss that or minimize that as it pertains or relates to their ultimate return to life. So the ability to take Fred into the community with the same treatment team that had helped him stabilize, quite honestly, and address the symptoms was paramount to his success. So, it's important to say that in our setting, in the setting in which Fred admitted, our offices are in those houses. My office was for 20 years was on the second floor of our intensive neurobehavioral campus, and there were bedrooms all around. So our therapists are in the situations with, having lunch with people, seeing people in the hallways in between sessions, and also interstitially talking with other direct care staff members and one another. So it really promotes a lot of, I think, integration and comprehensive treatment when you have that kind of setting. So the people that helped Fred stabilize and begin to learn skills were then the same ones from the same site that took him out into the community and collaborate him to make necessary revisions to his treatment plan in preparation for a return to home. So from admit to discharge, admission, extremely challenging, myriad complex symptoms immediately upon admission, and crises immediately upon admission. So establish stability in 3 key areas through our treatment philosophy and programming: stabilized medical, pain, vestibular, vision, all of those things improve sleep. We introduced, as I said, elements of behavior and cognitive programming to teach Fred techniques and promote his candidacy for self-management. If you can, referencing back to that awareness slide and self-management, and then ultimately beginning to give Fred a new vision for his activity plan when he returned home, which was, 6 hours away. And then for the return to home, Fred got it, which is what a cool outcome. Fred really saw it. He was able to slow it down. His symptoms resolved. He was a nice man, loved his family, worked hard, and he understood. He sort of got this thing, which I think was critical. And his wife and case manager now were educated. So they and Fred, first and foremost, were more ready for therapies in the community now. So Fred was, needed the intensive nature of our setting, but through our efforts and Fred's efforts, certainly, and his wife and case manager's efforts, I don't want to not mention those, Fred stabilized and was ready to go home and benefit from what was available to him in his home environment. And then what we also did for purposes of, I think, continuity of care and due diligence and all those things, we maintained 6 weeks of follow-up with our psychiatrist to help monitor things and also bridge the gap. So that person was available to Fred weekly, and then also available to inform our team, who was available to the case manager and Fred's wife, should anything begin to kind of change or shift on the home front that we could help address or at least inform through our knowledge about Fred. So having talked about Fred, a quick knowledge check. Which of the 5 ethical principles is highlighted in the actions taken by the team while supporting Fred's admission to ReMed? Again, if you could just use the chat feature. And I'll share my thoughts in a moment. Okay. So from my standpoint, whereas I felt Sarah, really, we respected her autonomy. And I also feel like, beneficence would have been an appropriate answer for Sarah. I mean, you could make a case for any one of these, of course, right? So it's more about which one's more emphasized, and some of that's a personal interpretation. I appreciate that. From Fred's standpoint, I think beneficence and non-malfeasance were key here. From a beneficence side, we really took a compassionate approach to Fred at all levels of care, from the moment he came in the door and how upset he was and how agitated and how threatening he was. We know professionally and clinically not to take that personally, that it's features of the brain injury and Fred's adjustment or lack of adjustment and coping with those things. And so there was quite a bit of compassion and taking positive action to help others, including what I was trying to do myself in the driveway, even with Fred, from a physical involvement, which is always precarious. And also certainly in the forefront of our minds, rather, was non-malfeasance, do no harm. Fred's had enough going on. He's had enough happen to him. Our environment is intended to be a safe place for people to get help, even when they're at their most unsafe. Our efforts are to establish safety and stability. And so I think for us, for Fred, the two ones that came to mind, ethical principles that came to mind to me were beneficence and non-malfeasance. And so what I really hope I was able to communicate today was, on the side of ethics, we all have our standards and principles and codes that we're required to adhere to and that we believe in and are committed to. But I think what's really important beyond that are philosophy and programming, and how that's actually enacted on a per case basis. So I hope what I was able to deliver this morning is a description of our philosophy and including awareness and how that impacts things, and how that can look so very different with two different types of brain injured folks. And every one of our folks that we treat is incredibly unique. And we take the same sort of highly individualized and comprehensive approach on a per case basis. So at this point, we have a couple of minutes left. If there's any questions, I'm happy to take questions from folks.
And those that may have questions, you can unmute yourselves, or you can also, if you don't want to speak, you can enter it into the chat box. And you could see Chris's email too. So if something pops in your head a little bit later and you'd like to send him a message, he put his email out, so it's fair game. So I know we have another speaker. Chris, we really appreciate you carving out time to, go over the ethics presentation to our Utah folks and to our Breakfast Club members. We all have spoken about how excited we are to hopefully have an in-person event and see everyone. And the next one is in August. So, Megan or somebody else on our team will send out more details in regards to that. And Megan, thank you again. Shout out to you for helping with the technology piece of the house too.
Yeah, you're welcome. I'm trying to get a hold of the Gardner Village to see if we can schedule that for August. So I'll let you guys know.
Fingers crossed. All right, with that, I'm going to do a warm, again, Chris, thank you so much for carving out time. And do a warm transition to my next teammate to introduce our next speaker.
All right. Thank you, Danielle, Megan, and all the folks that helped kind of just get this thing together for sure. And I really appreciate everybody's time this morning. Thank you.
Yeah, thank you.
Thank you.
Thank you.
Okay, our next speaker is Spencer French. I'm just going to read your bio unless you want to introduce yourself there, Spencer. Trevor said you might want to, but I can just read your bio if you want me to.
Well, how long is the bio?
It's really long because
Really
you're
long.
like, very special.
I can, Trevor thinks
Not
that I should do it. No, you can go ahead and do it. That's fine.
Okay. So Spencer has experience as a nurse in med-surg, ICU, and ER. He was hired in 2016 as a nurse case manager in Utah. He quickly acquired a regional reputation as a vital asset to challenging claims with multiple barriers to recovery. His clinical education experience as a nursing instructor at BYU makes Spencer a natural for overseeing all case management activities at Orchard and focusing on new initiatives to improve the workers' compensation arena. In his role, Spencer directs his staff of nurses to achieve positive claim outcomes by fostering a culture of critical thinking and continuing education. He implemented an innovative catastrophic training program in 2015 designed to anticipate our clients' needs for aggressive medical management of complex injuries. In August of 2015, Spencer was presented the Lifetime Achievement Award as voted by Orchard's employees. Thanks in large part to his leadership and vision, Orchard has realized its highest case manager retention ratio since being founded in 2001. He received his Bachelor of Science in Nursing from BYU, Rexburg, Idaho in 2003, followed by his Master's of Science in Nursing in 2006. And Spencer lives here in Highland, Utah with his wife and 5 kids. He volunteers regularly with the Special Olympics as a basketball coach and enjoys watching sports, camping, and traveling with his family. See, it wasn't that long.
Thanks. I wondered what that said. Good. So I'm trying to share my screen here. I don't know what you guys are seeing on your end.
You see probably your cute little boy in a robe.
Oh, okay,
Cute
great.
kiddo.
So let's see. How's that?
There you go.
Okay. Then I just need to move this thing over here. Okay, there we go. So always worry about technology issues doing these presentations on Zoom. So thank you, Chris, for your presentation. I believe you've already left, but and for showing me up on Zoom backdrop. I don't have any tool ups here in Utah. I just have a boring back wall with a window. So at least I have a window office. So I would also like to thank everyone for being on the call today and giving me the opportunity to speak on COVID-19 and return to work post-pandemic. Although we aren't quite in a post-pandemic stage, as the virus continues to reside here and in other states, and we continue to see deaths, but it definitely has dramatically decreased, which is a great thing and very encouraging. I apologize to those who have heard some of this presentation before. I know I presented this information to a few of you with your companies and also at other conferences, but I do have some updated information, so please stay tuned. I've worked in the work comp industry for over 14 years. I know that the bio said 2016, but I have worked since 2006 in the work comp industry. And I've got to know a lot of you that are on this call, and I think it's an awesome industry to work in, and great relationships have been built over the years. I currently live in Highland, and as mentioned, I'm the father of 5 wild children. Of course, I say wild because I don't know any of my offspring that would not be wild, I guess. Well, that's what my wife says anyway. So, and speaking of children, as you saw initially, my youngest is named Tice. And just about a year ago, I heard him talking to the other kids, and he said the coronavirus is dumb. And I thought that was funny. And as you know, kids like to repeat their parents, so that's probably what he was doing. So anyway, I pulled out my camera and I asked him to repeat what he had just said, and I wanted to show that. So hopefully I can get that figured out here.
The coronavirus is dumb.
Okay, so I hope that showed up, but now I can't get back on the Zoom. Oh, there we go. I was worried about getting out of the Zoom meeting. Can you guys see my PowerPoint? There we go. I'm back. Okay.
Yes, we can see it.
All right. So it's crazy to look back at that video and have no idea at that time the impact this virus would have on the lives of so many. That was back in April 2020 or May 2020. There's been so much sickness and death and difficulties due to the lockdowns and destruction of small businesses and people's livelihoods, to the negative mental impact of many individuals and especially children and who couldn't go back to school in person, and how we work and travel and how we have lived according to our beliefs, whether those beliefs were fear, cautiousness, anxiety, anger, sadness, skepticism, faith, hope, and on and on. Obviously, there's a wide range of experiences for those who weren't impacted in a big way and those who were dramatically impacted by the loss of loved ones. In fact, I read one story of a lady in Michigan who lost both her parents and her 2 brothers to the virus, so very heartbreaking. For my discussion today, I'll be breaking it down into 2 parts. First, I will be giving a short review on the latest updated information surrounding COVID. I'm going to cruise through a lot of the basic information that hasn't changed since the virus first came out, and we'll try to focus more on recent changes and additions to the CDC guidelines or results of studies that have come out regarding the virus and the long-term impact of the virus. And also touch on what we've been doing in helping those in the workforce who've contracted COVID and the hundreds of injured workers that we've worked with at Orchard. Second, I'll be sharing some feedback and real life experiences from our nurses who've worked with and helped hundreds of injured workers with COVID and the experiences that they had. One last thing I'd like to say before I dive into this presentation is you can imagine there are many contradicting stories and studies and articles and experiences and opinions surrounding COVID. It can be hard at times to distinguish what is fact, non-biased, non-politically driven. I get that our country, there's quite a division, what ranges from those who believe in everything from the CDC to WHO to Dr. Fauci to the government and everything those organizations say, and those who don't believe a word in a lot of those words that are said, nor do they believe in the accuracy of numbers that are out there. So I'd first like to dive into everyone's opinion on the virus and those organizations and wondered who would like to go first. No, I'm just kidding. Actually, can you imagine if we had that discussion? That would be crazy. So anyway, for the purpose of this information I'll be sharing today, I have stuck to the CDC website and proven studies or non-biased sources as they relate to COVID-19. So without further ado, let me jump right in. Okay, so there are many types of human coronaviruses, including some that commonly cause mild upper respiratory tract illness. However, COVID-19 is a novel new coronavirus that was first identified in Wuhan, China back in November 2019. I will get into a little more details on how it's spread, identified, and treated. I think we are all aware of the basic info on the virus, but let me share a little bit about the variants since this is a hot topic and one of concern for many. Information about the characteristics of these variants is rapidly emerging. Scientists are working to learn more about how easily they spread, whether they could cause more severe illness, or whether the currently authorized vaccine will protect against these variants. What we know, according to the CDC, viruses constantly change through mutation, and new variants of a virus are expected to occur over time. Sometimes new variants emerge and disappear. Other times new variants emerge and persist and spread. Multiple variants of the virus that cause COVID-19 have been documented in the United States and globally during this pandemic. The virus that causes COVID-19 is a type of coronavirus, and coronaviruses are named for the crown-like spikes on their surfaces. Scientists monitor changes in the virus, including changes in the spikes on the surface of the virus. These studies, including genetic analysis of the virus, are helping scientists understand how changes to the virus might affect how it spreads and what happens to people who are infected. Multiple variants of the virus that cause COVID are in the United States, as mentioned. There are currently 5 variants in the United States. I won't go into the specifics of those variants, but some have originated in the UK, South Africa, and Brazil, and some actually from within the United States. Either way, these variants are all now here and most likely in the state of Utah. These variants seem to spread more easily and quickly than the original COVID-19 virus, which may lead to more cases. An increase in the number of cases will put more strain on healthcare resources, lead to more hospitalizations, and potentially more deaths. There is potential of another wave due to these variants. However, studies so far suggest that antibodies generally through vaccination with current authorized vaccines are recognizing these variants and fighting them. This is being closely investigated and more studies are underway. They're studying these variants to detect how they spread, the severity of the disease. But I've also heard that of people who have had COVID, got over it, and then they are catching the variant, but not having as severe as symptoms as before, which tells me that the vaccines are working for these variants, as well as the immune system of somebody who's already built up immunity towards it. So hopefully that continues, and those are all really good signs. To quickly share some numbers, the current count of cases of COVID-19 in the United States as of last night, total cases, 31.8 million, total deaths, 568,000. Worldwide, if you were wondering, total cases, 141 million, deaths, 3.01 million. So compare that to the Spanish flu of 1918, and this is pretty fascinating information, over 500 million. And at that time, it was 1/3 of the world population that had caught the Spanish flu. So for us today, that would be 2.55 billion people catching COVID or would need to test positive for COVID. Deaths, there were 50 million people who died from the Spanish flu. So for us today, that would equate to 247 million people would need to die from COVID to reach the Spanish flu numbers. And we are at 3 million. I don't want to minimize the deaths from COVID, but for discussion purposes, COVID-19 isn't even close to how severe the Spanish flu was in 1918, as I sometimes hear those comparisons. For the state of Utah, total cases, we've had 393,000, total hospitalizations, close to 16,000, and total deaths, 2,174. The death rate for the state of Utah is 0.0055% for all those who have tested positive for COVID. In the US, it's 0.017%, according to the numbers I obtained off the CDC website. And obviously more people have caught COVID-19 and were never really tested, so they wouldn't be included in those testing numbers, but that's actually good news because it decreases the mortality rate even more. Again, I don't want to minimize the impact of the virus, especially those who've lost loved ones or those who are surviving with complications. I just want to point out the numbers that are out there according to the CDC and how they may contradict what is heard or what's on the news. In fact, I talked to a guy a couple months ago that we kind of had a little discussion that he said that the death rate was 10 to 15%. Which is crazy. So I requested to him to turn off the news, but I just think we have to really line ourselves with the facts. I think that's extremely important. Currently, the state with the most cases in Michigan has 70 cases per 100,000 people, and in Utah we have 11 per 100,000 people. And so Utah is doing extremely well right now, as many of you probably know are aware of those numbers. Okay, as you are also aware, it spreads from person to person, especially those who are within 6 feet through respiratory droplets. However, a recent retrospective statewide cohort study by Oxford Academy, which tested the effectiveness of 3 versus 6 feet of physical distance for controlling spread of COVID-19 among primary and secondary students and staff, concluded that lower physical distancing policies can be adopted in school settings with masking mandates without negatively impacting students or staff safety. The CDC still suggests 6 feet social distancing, but it states that schools are okay at 3 feet. And of course, airplanes now are 1 to 2 feet. When I flew to California a couple months ago, the middle seats weren't being booked, but now they are, from my understanding. So now it's 1 to 2 feet on airplanes, which is wonderful. There is little to no evidence of the virus spreading through food or from surface to surface. Also, in general, the more closely a person interacts with others and the longer that interaction, the higher risk of the virus spread. And this is called viral load. And this is important because it's a major source of the 3,600 healthcare workers who have died from COVID-19 since April 7th. I looked for, I couldn't find more information or updated numbers on that, but out of those 3,600 healthcare workers, more than half of those were under the age of 60. And out of those, roughly 1 in 3 were nurses, but the total also included physicians, pharmacists, first responders, and hospital technicians, among others. In Utah, there were 16 healthcare worker deaths, which ranked Utah as the 9th state for the fewest healthcare worker deaths. So that's also another positive number, but death is never a good thing. So regarding asymptomatic spread, this is always a big topic or discussion or concern or wonder. And asymptomatic is those who are not showing any kind of symptoms really with having the virus. And this has been a challenging discussion because the CDC has changed their minds and gone back and forth on how much an asymptomatic person can spread the virus. It's really hard to discover that information. And last June, the World Health Organization came out and said asymptomatic spread was rare. And then they walked back their comments a few days later. According to the CDC, asymptomatic spread has been one of the most mysterious and haunting aspects of COVID-19. I mean, it's a big deal, right? The shutdowns were due to the assumption that asymptomatic spread was high, and people who were even near somebody were asked to quarantine. So it's kind of a important thing to know for sure. And I wish we had better data on that. Research early in the pandemic suggested that the rate of asymptomatic infection could be as high as 81%. But a meta-analysis published last month, which included 13 studies involving 21,708 people, calculated the rate of asymptomatic presentation to be only at 17%. I found studies that backed asymptomatic spread and studies that couldn't conclude that asymptomatic spread was a driving force. However, common sense would indicate that if the virus is spread from person to person, mainly through air particles, that those who have an active cough and symptoms would be the ones who spread the virus the most, similar to how the flu is spread. So if one has symptoms, staying home would obviously be extremely important. As of today, the CDC does say that asymptomatic spread is possible. And so the recommendation of social distancing, mask wearing, and et cetera are still in place. Regarding school transmissions, we now have ample studies that COVID is rarely transmitted from persons in school. Thankfully, many schools in many states are following the science and have in-person school. One particular study that recently came out determined that transmission of COVID-19 in schools is extremely rare. In a collaborative study between Duke University and the University of North Carolina, Chapel Hill, researchers discovered that among 11 school districts with nearly 100,000 staff and students, there were no instances of children passing the coronavirus to adults during in-person instruction. Researchers found just 32 cases of either kid-to-kid or adult-to-adult coronavirus transmissions over 9 weeks. The study concluded that schools can stay open safely in communities without widespread community transmission. And that's with masks. I need to clarify that study and these studies are talking about with the kids actively wearing masks. Clinical manifestations, symptoms may appear 2 to 14 days after exposure to the virus. And these are the most common symptoms, with fever being the highest, almost everybody having a fever that had symptoms, fatigue and dry cough being high up there, all the way down to other reported symptoms. And this isn't all the symptoms that are presented. There's been some crazy random symptoms that have been presented out there with COVID. If you look at the list, it's about every symptom that a person can have. So they had to put something on the list that presented itself. But these are the most common. Regarding severity, studies show that at least 80% of people who have tested positive for COVID-19 have no symptoms or very mild symptoms. 15% are severe infections, and similar to the flu, and 5% end up critical, requiring ventilation or end up dying. Those hospitalized, especially placed on ventilators, dramatically increase the chances of death. In a study that included 2,741 patients who were hospitalized for COVID-19 in New York City, in the New York City healthcare system, 665 patients, or 24%, died or were discharged to hospice. Of the 647 patients who were actually on invasive mechanical ventilation, 60% died. 13% were still ventilated and 16% were discharged by the end of the study. When I hear someone needing to be put on a ventilator, it's disheartening because the chances of survival are not good. And that's why they are doing everything possible in the hospital setting to avoid putting people on ventilators. I did speak to, I'm on a lot of nursing Facebook pages, and I made contact with somebody who caught COVID and they ended up being in the hospital. They were on a ventilator for 11 days and they came out and survived. And I've been in contact with her off and on to check on her, see how she's doing. And she, in one of our conversations, she reported that she went in the hospital the same time as 4 other individuals. All of them were put on ventilators. The average was about 11 days, and all of them made it through, and all of them survived, which is a miracle, which is fascinating given those statistics I just shared. And so you just never know what someone's body's going to do that's put on a ventilator. It's a definitely tough situations all around. In speaking to her recently, she reported that fatigue is by far the #1 continued problem that she has, just getting that stamina back and that energy, even though it's been almost a year now. And I'll get into a little bit of that for long-term effects here in a minute. Okay, at risk, this is not new probably to everybody as well. Among older adults, the risk for severe illness from COVID-19 increases with age, with older adults at the highest risk. And as you can see by the chart, how much hospitalization and death dramatically increase with age. Those who are over 85 years old have a 630% times more likely chance of death than those who are 18 to 29 years old. All the more reason to protect the vulnerable. There are also other factors that can increase your risk for illness, and that's pre-existing conditions, which I will get to on the next slide. And then another high-risk group is minority groups. There are various reasons for why some minority groups are 4 to 5 times more likely to be hospitalized or die from the virus. I won't get into too much detail in this area, as the CDC provides various reasons why minority groups are at more risk, but it's definitely important to be aware of this higher risk group, as to provide measures that focus on the most vulnerable. So I wanted to dive just quickly into those pre-existing conditions because of how important they are with this impact of the virus. This is a list of pre-existing conditions. It changes here and there, but these are the strongest and most consistent evidence that they see out there. And as you can see, there's cancer, chronic kidney disease, COPD, Down syndrome, heart disease, obesity, severe obesity, pregnancy, sickle cell anemia, smoking, type 2 diabetes. Just as of last December, Down syndrome, obesity, and smoking were all added to this list. It used to just be severe obesity, but now it's obesity in general that were just added. And then these are mixed and limited evidence, pre-existing conditions. Mixed is there's conflicting studies that are out there. So these are mixed issues or such as hypertension, asthma, pregnancy, those kind of things. And then limited there's just very, very limited studies, but it makes sense because a lot of those things aren't high diseases, I guess you should say. BM transplant, HIV, liver disease, type 1 diabetes, that kind of stuff. So it's very important to know these pre-existing conditions. Protect yourself and others. So I won't go into too much detail on this slide as it's straightforward. You can protect yourself and help prevent spreading the virus by washing your hands, avoiding close contact, covering your mouth and nose when around others, covering your coughs and sneezes, cleaning and disinfecting, and monitoring your health daily. And I'm sure all of this has been drilled into everybody's heads by now. Testing, there are 3 kinds of testing. Hopefully I can help clarify these. PCR test tells you if you've had COVID-19 right now and could spread it to other people. So PCR test looks for the genetic material of the virus. It's a very accurate test. A healthcare worker uses a nasal swab to collect a sample from your throat behind your nose. The antigen test or rapid test, it's kind of new, but you can get results in minutes with this. An antigen test looks for proteins found on or within the virus. It tells you if you've had COVID-19 right now and could spread it to other people. Like a PCR test, a healthcare worker uses a nasal swab to collect a sample from your throat behind your nose. However, there is a higher chance of having a false negative test result with this test. In fact, recently we had one of our nurses in New Mexico who attends appointments and at this one particular doctor's office, and the office requires that every person that comes in gets tested when they arrive. So she got tested and it came back positive. She was pretty shocked because she had COVID in January. She had received both of her injections in February and was just really surprised that it came back positive. She said, "How can this be? I've had my injections and I've even had COVID." And the worker said, "Well, it says positive and these tests are never wrong." So knowing that these tests aren't fully accurate because that result would require her to quarantine herself, we had her go and get 2 different tests from 2 other different facilities, and both tests came back negative. And so yes, there are false positives that do happen. Then there's the serology or antibody test. And this may be able to tell if you've ever been exposed to the virus that causes COVID. A positive antibody test does not guarantee immunity to COVID-19, but a sample of your blood is collected and used to see if your body has made antibodies to the virus. So basically you've had it, you built antibodies and maybe didn't even know you had it. And that is as I mentioned, about 50% of the population that may be walking around with these antibodies and have no idea they've had COVID. Regarding high-risk settings, I surveyed nurses who work in long-term care facilities, and the protocols are different for each facility, but in most cases, employees are tested twice a week with rapid tests, and if they have a positive employee, then they must test the residents weekly for 6 weeks with the same test. Some other facilities were testing both the employee and residents twice a week. So I think that's great to see all that testing occurring in those high vulnerable populations. Okay, prevention. There are some preventative measures we can take to avoid the serious symptoms or complications that arise from COVID. Obviously, following the CDC guidelines can help prevent us from getting the virus. However, many follow the guidelines and still get the virus. So what can we do to help us decrease our symptoms for if or when we catch COVID? Our personal health plays a major role in how severe our symptoms will be with the COVID. It is well known that being healthy and exercising improves our immune system. However, specific to this disease, studies about the impact of vitamin D, vitamin C, and zinc have been enlightening and encouraging. There's growing evidence that an often overlooked vitamin D may have a protective effect against COVID-19. Several studies have shown that COVID-19 patients who are deficient in vitamin D are more likely to experience serious illness, severe complications, and increased risk of death. One study showed that when hospitalized COVID-19 patients took oral vitamin D supplements as part of their treatment, they were significantly less to be admitted to the intensive care than COVID-19 patients who did not receive vitamin D supplements. A few facts about vitamin D. 40% of Americans are believed to have lower than recommended levels. Americans with darker colored skin are less efficient at producing their own vitamin D. Older adults may experience deficiency because of their skin may not make vitamin D and they may not get outdoors often. And obese individuals have lower vitamin D because adipose tissue, which is fat, absorbs and holds the vitamin D so it can't get into the bloodstream and body like it should. So it's no wonder that COVID is greatly impacting the elderly, the obese, the minority groups, as they are most likely the ones who are deficient in vitamin D, and 40% in the United States. So those are big numbers. Vitamin D is a big helper with the immune system, and it's contained in foods. It's in the sunlight, fatty fish foods, salmon, egg yolks, mushrooms, fortified dairy products, those kind of places. So that is one way that you can definitely help yourself with COVID and give yourself a better fighting chances to make sure your vitamin D, vitamin C, and zinc are effective. And okay. Treatment options have consisted primarily of conventional care, with most antiviral regimens remaining largely experimental, pending quality trials. So there's one drug that's been approved by the FDA, and that's remdesivir, and it's an antiviral, and it's showed that it shortened recovery time by a third in some patients and has had great success. The other treatment options for COVID-19 are reducing an overactive immune response, treating the complications. So maybe someone develops a bacterial pneumonia, then antibiotics can be given. Obviously, antibiotics wouldn't work for a virus, but other secondary complications that occur should be treated so that there's not a snowball effect on that person's condition. And of course, supporting the body's immune function, which I've talked a little bit about, and then convalescent plasma. And so what that is they take someone who's had the virus, they take their plasma and they put it into somebody else to help them who's suffering from symptoms and complications of the virus. And there's such a huge positive response to that. And we saw that several times with our injured workers, that was one of the things that seemed to help them the best, that within 48 hours, all of a sudden they just had a huge difference in their health and their energy after they had that plasma transfusion. Vaccines, currently 2 vaccines are authorized and recommended to prevent COVID-19. There's the Pfizer, which is 2 shots, which must be done 21 days apart. The first one helps the immune system create a response. The second one strengthens that. The Moderna is similar, 2 shots over a 28-day period. You can't mix those. You can't get the first shot from Pfizer and the second shot from Moderna. It has to be the same company. And of course, there was Johnson & Johnson that was approved, but now it's currently on hold. And that was just a 1 shot. However, as you probably all heard, they stopped that because of the clotting issues they were concerned about. And then recently the FDA inspection has gone into a few factories and discovered uncleanliness and that kind of stuff. And so one inspector for the FDA didn't think that Johnson & Johnson would even start producing again after the issues they found. But I don't know, that's just what I recently read. That's just as of yesterday. So, and then there's others that are pending authorization right now. I did write down, I thought, oh yeah, right here. People vaccinated in Utah, there are 1,222,333 people in the state of Utah have been vaccinated. That's awesome. That's a lot. So between that and those who have probably had the virus and are immune, and the combination of those two, we're probably close to or getting closer to herd immunity in Utah, which is a fantastic thing, and probably why we've seen a dramatic decrease in positive cases and deaths. All great news. Okay, so since COVID-19 was only discovered a year ago, its long-term effects are unknown. Severe acute respiratory syndrome, or SARS, it's a coronavirus that emerged in 2003, causes very similar symptoms and complications as COVID-19. So there's some assumption out there that the long-term impact will be similar. So a few studies that have been done on SARS, a study of the long-term effects of SARS, remember since 2003, so they've had a lot more time, was undertaken in Hong Kong, showed that 2 years after they had the disease, 1 in 2 SARS survivors had much poorer exercise capacity and health status than those who had never had the disease. Only 78% of the SARS patients were able to return to full-time work 1 year after the infection. Another study also done in Hong Kong revealed that 40% of people recovering from SARS still had chronic fatigue syndrome 3.5 years after being diagnosed. And given the multi-organ effect of COVID-19 on the body, survivors may have a variety of long-term effects on other organs, included what some doctors are calling post-COVID lung disease. There are stories or studies that have been conducted in China that indicate lasting effects of the virus on the pulmonary, cardiovascular, kidneys, and nervous system. Now, with that said, these are more severe cases. So I'm not talking about someone who got it, had some sniffles, and then went back to their regular life after 10 to 14 days. These studies were those who were impacted dramatically by it, who had been hospitalized, and although they survived, came out of the hospital, and got back to their life, still had these kind of complications down the road. So hopefully it's not similar to SARS. Hopefully COVID doesn't have that long-term impact, but that's about all they have to compare it to right now at this time.
Spencer, we have a question.
Yeah.
What are the circumstances under which the antibody test is called for and paid for by insurance?
That's a good question. I don't know that a lot in detail. I do know that for us, for our nurse, that there are insurance companies that individuals have that will pay for the full amount of a test. And then and from my understanding, this particular doctor's office is waiving the copay, and then if there is a copay, and then they're just charging the insurance company. So it's not costing all these patients in regards to them directly out of their pocket, but they're definitely charging the insurance companies, which some people have opinions on that, whether that should occur or not. But that's a great question. That's all I've heard. And if anyone can chime in, either talking or chatting about that, either now or after my presentation, that knows more about that, that'd be great. That's a good question. I wish I knew more details. Okay. So psychological impact, the outbreak of coronavirus was and continues to be a very stressful event for many people. In fact, anxiety and depression has dramatically shot up among adults and children. Fear and anxiety about a disease can be overwhelming and cause strong emotions in both adults and children. I believe we haven't even touched on the negative psychological impact the lockdowns and and lack of children going to in-person school has had on children and what long-term impact there will be. I just hope that we learn from all of this that occurred. But cognitive behavioral therapy is most widely used treatment for COVID, and we've actually seen success in our own injured workers getting CBT who are mentally struggling, and really helping them feel more comfortable, get over that anxiety and fear, and getting back to work. Sorry, I can't see questions pop up, so I can look at those after I'm done, or
We got you covered.
Yeah, we
Okay.
got you.
thank you. Okay, so let's dive into COVID and workers' comp. So it's anticipated that many people will or have contracted COVID-19, and whether that was on the job or not can be a very tricky situation. Obviously, the acceptance of a claim will be determined by each state and by each adjuster, each company. We are finding that most of the claims are from healthcare facilities or factories. At least that's what we've seen. And that's the accepted work comp claims, I should say. According to the Department of Labor, it states that the DOL acknowledges that it's difficult to determine the precise moment and method of virus transmission. Therefore, when an employee claims FECA benefits due to COVID-19, federal workers who are required to have in-person and close proximity interactions with the public on a frequent basis, such as members of law enforcement, first responders, and frontline medical and public health personnel, will be considered to be high-risk employment. In such cases, there is an implicit recognition that a higher likelihood exists of infection due to high-risk employment. So the decision surrounding compensability is not my expertise, nor responsibility or authority, so I will yield to the adjusters and attorneys on those matters. I'm going to dive into these things here in a little bit, or next. COVID impact on work comp, employee to employer considerations, re-entry criteria, and helping injured workers who tested positive. So what's COVID's impact on workers' compensation in general, the work comp industry? And this was perfect timing. Just last week, there was a article came out. So this was taken recently from Joe Peduta, who is the principal of Health Strategy Associates, and he runs a well-known blog called Managed Care Matters. I don't know if you guys are on his blog, but he's very tapped into the insurance industry in general, but the work comp industry, and knows quite a lot of people, hears a lot of things, sees a lot of things. So he provides a lot of good information. So I thought this was interesting. So Joe breaks down a recent article where concern was raised by a Mark Walls in a tweet that was noted in a recent article in workerscompensation.com. The question posed stated, could COVID have a very alarming potential outcome that could have a huge impact on workers' comp dues to claims for neurological and psychiatric issues? So what does the future look like? Is there going to be tons of claims, all these issues, and it's going to cost lots and lots of money? He said a few days back, The Lancet published a study assessing the neurological and psychiatric outcomes or diagnoses of about 236,000 US COVID survivors. And the key findings that there was a statistical correlation between COVID-19 and higher frequency of neurological and psychiatric diagnoses. And these diagnoses were more common in patients who had been required hospitalization, and more common still in those who had required ICU admission and had developed encephalopathy. The researchers compared the increased frequency of these diagnoses in COVID survivors to increases in similar set patients with non-COVID respiratory diseases, including the flu. So naturally, this would be alarming for workers' comp claims and the future costs or long-term costs for those claims, if indeed this study was accurate in its findings. However, there are a few things that Joe points out that does kind of debunk this information and provide some great points on why it's unlikely that there will be a long-term high cost that will impact workers' comp for thousands of companies. And so some key considerations, the people with the most risk are older and less likely to have contracted the disease at work. The study did not show a causal link between a statistical correlation, and correlation is not causation. There have been relatively few COVID claims accepted by work comp, and only 2 states have actually passed broad presumption laws. So what does that mean? Well, Mark says in this report, we've never had a global pandemic where the government has mandated it be covered under workers' compensation. Well, we still don't have that. I'm not sure which, if any, governments have broadly mandated COVID be covered under workers' compensation. Sure, some states have passed presumption laws or had executive orders regarding presumption, but those are few far between, rarely cover all workers, and typically come with rebuttal presumptions. So only California and Wyoming cover all workers with a rebuttal presumption. Several states, New Jersey, Vermont, and Illinois, cover essential workers with varying definitions thereof. And then Minnesota and Utah, so this really relates to us, and Wisconsin only cover first responders and healthcare workers. So there's a lot of fear out there about COVID, including the cost of work comp industry, but much of that fear is simply not fact-based. As of right now, there isn't a lot of evidence to indicate that there'll be long-term costs to workers' comp, as explained by that information provided in that article. So employee-employer considerations. One thing we do hear a lot of, one of the biggest concerns coming from injured workers, family members, adjusters, risk managers is exposure. What's the protocol if an employee is exposed by a family member? Can they work? Should they work? What if this happens at work? The entire staff could be affected. Each state has their own protocol. The CDC website is all over the place. They do note that the impact of the quarantine on the employer and employee are huge. Here's what I found. Employees should notify their supervisor and stay home if they have symptoms. Sick employees should follow CDC recommended steps. Employees should not return to work until the criteria to discontinue home isolation are met in consultation with healthcare providers and state and local health departments. Employees who are well but who have a sick family member at home with COVID-19 should notify their supervisor and follow the CDC recommendations. So yeah, my spouse has COVID, test positive, I'm with them, probably don't want to go back into work. The CDC states if you were within 6 feet of someone who tested positive for more than 15 minutes, you should quarantine for 14 days. However, there are options to reduce that quarantine time. Your local public health authorities make the final decision about how long the quarantine should last based on local conditions and needs. I think I would guess, or at least I would personally, if I was told I was next to somebody for longer than 15 minutes close by and they just tested positive, I wouldn't quarantine myself for 14 days. I would go get tested and want to see if I was positive so that I could decide based off of the test on what I wanted to do. So this happened to my daughter at school. They called us and said she sat next to somebody who tested positive. So they said she can either stay out of school for 14 days or she can come back after she gets tested. So we went and got her tested. Of course, she was negative and went back to school. So if an employee's...
Spencer, we do have a comment, not like a question, but somebody, they have an adjuster said she has a long hauler who got COVID last April. She developed neural problems and she still has not returned back to work. Yeah,
we do find that there are definitely some that we still have some that we're working with right now that are having those long-term issues, and we are having them see physicians and kind of turning it into we originally had what we call COVID claims, and then now they're full case management claims because they are still receiving treatment. So we've seen some of that. It's more rare than common. And so that's not unlikely that could occur. And so hopefully they get that figured out and get her the help that she needs. And hopefully they'll be able to treat the symptoms, and then hopefully the underlying disease will, the body will take care of itself. So. But thanks for that comment. Yeah, you confirmed that there are some long-term effects for sure. Okay. Okay, I would venture to say each employer has determined how to best help their employees and to handle each situation. Our company, we had to write a policy keeping us in compliant with the law and how we handle COVID positive employees. And each company will need to determine their own protocols and utilize the laws and the CDC to do so. And I'm guessing that most have done that already and already have something in place, especially because it's been a year now. And so there's a good chance somebody may have they've already gone through that. And quite a lot of people are working from home and have that ability as well, which is a fantastic option. Okay, so really quickly, because I'm already at 40 minutes, I need to talk faster. Return to work criteria. So according to the CDC, there's a specific return to work criteria for suspected or confirmed cases. There's symptomatic with suspected or confirmed COVID, and asymptomatic with suspected or confirmed COVID. Asymptomatic being no symptoms are shown. So symptomatic with suspected or confirmed COVID, symptom-based strategy. This is where an injured worker is excluded from work until at least 24 hours have passed since recovery, defined as resolution of fever without the use of fever-reducing medication and improvement in respiratory symptoms, cough, shortness of breath, and at least 10 days have passed since the symptoms first appeared. So we most of what we got did have symptoms, and we based that return to work off those symptoms. And injured workers were not required to go back to have a negative test to go back to work or to integrate back into society. They just had to meet this criteria, that time passing and the decrease in their symptoms and the fever, and then they could just go back to work without any kind of release from a physician. Asymptomatic, we didn't deal with too many of these, but this is obviously time-based strategy because there's no symptoms, so you can't base it off a symptom-based strategy. And they're excluded from work, and 10 days have passed since the date of their first positive COVID-19 diagnostic test or their exposure to somebody that had it. So that's 10 days. They never develop symptoms. Now, if they do develop symptoms and they're on this time-based strategy, once those systems develop and kick in, then they start over under the symptom-based strategy because now they have symptoms and now they've got to start and get to that 10 days with those symptoms, if that makes sense. Or I hope I explained that right. And so what did we do, or it says what are we doing, but what have we done? Just more so because we're not really seeing a lot anymore, which is awesome. We don't want to see COVID claims. We don't want to see COVID at all anymore in this world for the rest of our lives, although it may be here to stay. But it's great to see that it's has decreased so dramatically. So when this first occurred, we knew that we would probably be seeing this in workers' comp because of some of the companies that we deal with and work with. And so we jumped in and hurried and developed a COVID program where we do a COVID-19 file review, COVID symptom tracking, and COVID case management. And then we provided some in-depth COVID training to all of our nurses at the very beginning to give them an update on all things COVID that we knew at that time and how to help injured workers if they were to get a claim. So I'm just going to buzz through this really quickly. So our nurses were set up with the ability to investigate the claim or potential claim and we utilize the CDC investigation form. And so we would interview the injured workers and obtain all this information and then determine if they could have caught it outside of work or determine if they had very specific incidents or an incident where they were with or around somebody that tested positive for COVID and they may not have had the proper PPE on or whatever. And so it was very likely, according to this investigation, that they caught COVID at work. And then it was, we provided that information to the adjuster, and then they determined whether accepting that claim or not under workers' comp and whether it was compensable. Obviously, we don't do that as nurses. So the adjuster would ultimately make that decision. But we would know what the decision would be made based off the investigation form because it was pretty obvious for the most part that they did catch it at work. We did have some that didn't, though, that we determined that they didn't. But COVID, we did COVID-19 symptom tracking. So the second service that we did was assisting with managing the COVID claim or symptom tracking. So the nurse checked in with the injured worker daily for a symptom check, especially fever and cough, which were two of the most common symptoms. So depending on where they were symptomatic or asymptomatic, the symptoms are the key to the driving force that to no longer having the need to isolate and when to return to work. For those who hadn't been tested, known exposure, and started to develop symptoms, initiated a referral to get tested. Sometimes that occurred, or an assumption that they definitely were positive for COVID. And of course, those who had already tested positive and worsened needed to seek further medical care when their symptoms reach an intolerable level, especially shortness of breath. the injured worker was safe to return to work when they met the return to work criteria as outlined by the CDC, which I already explained in previous slides. And once the injured worker returned to work, then we would no longer be working with them, because that was our goal, to make sure that they safely got through the symptoms they were having, the problems they were having, and that they knew that, okay, I'm going to return to work 10 to 14 days at this time when my symptoms decrease. And this is what it looks like, and say, because people would, and I'll share some stories here in a little bit, but people would be concerned that that they couldn't go back, and they didn't know when to go back, and they didn't want to infect their coworkers. And so they would want to stay out longer. And we found that some people planned on staying out until they were ready to go back, rather than staying out until it was time for them to safely go back according to the CDC guidelines. So we either played a big role in helping people go back to work when they were supposed to, played a role in helping people develop severe illnesses by watching them closely, monitoring their symptoms, and helping them get in to see a physician because their symptoms were getting severe enough. You would think that they would do that themselves, but that wasn't necessarily the case, because, well, especially if we're dealing with nurses, right? I'm a nurse. I know a lot of nurses, been around nurses a lot. We don't take care of ourselves very, very well. And so we are on our deathbeds, I think, before we will go seek help. So at least that's my experience. And then the third service that we provided were case management. These are the claims that after that initial time period of when they should return to work, these are ones that continued on to have, they needed oxygen, they needed long-term oxygen, they continued to have serious fatigue, neurological issues, cardiovascular, those kind of things. So we continued on those claims, or still to this day continue on some of those claims, to work through that with them and make sure they get the care that they need to get back to normal as much as possible. And I hope that they all do. And then monitoring those who were inpatient in the hospital. We did have ones that went inpatient, ones on ventilators. I believe we unfortunately had one that did pass away, but we did work closely with the hospital case manager and with the training that was provided to the nurses. They were able to work closely and look at these updates with labs and CT scans and blood gases and all that kind of stuff to provide that update to the adjusters. So real life experiences, you can't get better than that, I guess, or what the nurses' experiences. So we've worked with several hundred injured workers and their COVID claims. Several of our nurses worked closely with these injured workers as they caught COVID, tested positive, developed symptoms, mild to severe. And I'd like to share their feedback, what they experienced, with a couple impactful stories. So case managers experienced, this is a past tense since COVID claims, as I mentioned before. We don't do a lot of them now, so these are past experiences. After being diagnosed with COVID, the injured worker self-quarantined at home, recommended to be in a separate bedroom and bath. The symptoms are treated conservatively at home, and this can be a scary time for the injured worker. The case manager offered education and support, just knowing that they had someone to call and talk to with information and to express how they were struggling, whether it be mentally or physically, was very important. In fact, one nurse or one of the injured workers was having some difficulty and tried to contact the doctor's office. They told her they'd call her back. They ended up calling her back 6 hours later. Whereas our nurses, we tried really hard to be available right when they called as much as possible to relieve that stress and anxiety, and from them taking themselves in when it may not have been necessary. Having someone checking in on them relieved a lot of their stress. The biggest impact came from building trust and a relationship with the injured workers so that they had more reasonable outlook when it came to treatment and getting through the process. As the statistics prove, most of them had mild symptoms and returned to work at the timeline, 10 to 14 days. Although many times injured workers would express their concern, as I mentioned, that they had some anxiety to return to work as they felt that they still may be contagious, or that they would be viewed differently from their coworkers when they returned, kind of like they have the cooties or something. But many injured workers would return and be welcomed by their coworkers instantly, easing those concerns. By a nurse being on the claim and having daily contact and conversations with the nurse would mentally prepare the injured worker that return to work at the time they would no longer be contagious was the goal. Our nurses who worked these claims expressed that they had not been involved, had they not been involved in those claims at the onset, they believed that some of these injured workers would have not returned in a timely manner. So what did they see the typical treatment options? So I'm getting feedback from my nurses here. What did they see as the typical treatment options and what worked the best? Over-the-counter Tylenol seemed to have the best outcomes. However, some did use ibuprofen. Hydration was always pushed to avoid reaching a severe dehydration point. The loss of smell and taste made people not wanting to drink or eat. Nurses gave encouragement and reminders and ideas to try different foods, which was helpful. And rest, there was a fine line between rest and sedentary. Reminders were given all the time. Deep breaths and move around were helpful. So these nurses kind of played their nursing role or the mom role. I need you to get up. I need you to drink. I need you to eat. I need you to stay as healthy as much as possible. I know you feel like crap, but I really need you to do this so that the injury doesn't, or so the virus doesn't take you over. Most of the symptoms for most of the injured workers lasted about 5 days. If the respiratory complaints were ongoing and fever more than 4 to 5 days, then there was some antibiotic therapy of azithromycin, doxycycline that were very helpful and prevented the development of pneumonia. If a cough was ongoing, typically prednisone and cough medications were helpful to help clear up the bronchial irritation. And that's another thing the nurses played a big role in, is there was a lot of doctors' offices and places that would not see anybody that was positive for COVID. And so we determined which places these injured workers could go, could get them in quickly if needed, rather than them have to call around, be turned away, because we know that was happening. Most of these cases just took time to resolve. The key was not pushing too hard, but still challenging the injured worker, allowing them some ownership of the illness and validating that they are or have been super sick. We had to remember that the injured worker wasn't getting this validation from anyone, and some were looking for that validation with ER visits or MD visits and going there and wanting to go there. However, unless they were severe, they would not see them or they would turn them away. So even places like that, we're saying, just stay home. There's nothing we can do for you. There's no treatment you can provide. If you come out, there's a chance you'll infect somebody else. So there wasn't a lot of sympathy, I guess, or validation is what I'm trying to say. However, with that said, there were times when the nurses would suggest the injured worker get some help depending on their vital signs or how they sounded on the phone. One injured worker stated, so this is quoted from an injured worker, "Having a nurse case manager saved me from getting admitted to the hospital. She recalled during the daily calls from the case manager, she told me that I sounded worse and explained that I had been trending my temperatures upward and they were consistently elevating. I was not aware of this. She stated that I did not sound good and sounded different from the days prior, and my temperature continued to rise. She recommended that I seek care and even help me locate a provider. Not too many providers would see positive COVID claims, so that was helpful to have her line someone up for me. She was correct on the recommendation. As I had developed bilateral pneumonia, I was treated with antibiotics and cough medication. I recovered quickly, and now I am back to work. I was really sick, and I was convincing myself I was okay, and I wasn't. I bet I would have had to be admitted to the hospital if I had not gotten care when I did." Once the contagious stage was over, the short-term impact COVID had on injured workers was weakness and no stamina. So our experiences align with what we read in here. It totally wiped people out. Once the virus was done, then working back, that endurance was the biggest issue that these injured workers had. We also found that 50% were ready to return to work with no issues on day 10, no fever, 24 hours, I'm done, get me back to work. Overall, 75% were done by 14 days, but 25% of those didn't have the stamina and continued to cough, was troublesome, that was troublesome to them that they still had some kind of a cough and hadn't returned to 100% baseline. And so that was a concern. Although temperature decreased and all the other signs were fine, they had a little bit of cough, but a little bit of cough was okay. As long as those had improved and there was no fever and the time had passed, according to the CDC recommendations, they were okay to return to work. So we had to tell them, you have a little bit of cough, but you're okay. You have a little bit of fatigue, but it'll get better. 25% needed help with coordination of care, return to work, and treatment plans to be established because their symptoms and issues carried on past the 14 days. These 25% needed a taper back to work plan with modifications. They ended up needing an office visit or two to assist with the plan, and sometimes medication intervention was given for recovery. This group needed the case manager to advocate and check in on the injured worker, seeing and acknowledging the improvement and having a plan ready and continually encouraging that plan. And so some people are like, they were pretty, I don't want to use the word stubborn because I don't want to downplay the fatigue and the symptoms of the injured workers, but they just needed more, they needed a physician basically to work with them and give them a taper back to work plan. And that did occur with about 25% of who we worked with. Since there was no MMI or return to work needed for COVID claims, it was educating the injured worker that once they met the criteria, they could get back on schedule. So, and there's some that, as I just mentioned, would not return to work without a letter from the physician, and some that wouldn't return to work without a letter from their employer. So, and of course, we dealt with some that felt owed or felt that the employer could have done more to help them prevent them from getting the virus. But thankfully, those were only a few. We did have some that required hospitalization and are continuing to receive some care today. We also worked with one young nurse who ended up flying to Florida for a double lung transplant. She spent several months down there and is doing fantastic now. I think she's returning soon, and one of our nurses has actually been continuing to help her get from Florida back to Utah and coordinating that flight for her. And I'm sure you've heard of those stories. It's been on the news. It's been on KSL with this particular nurse. It's an awesome story. It's a miracle and how she's recovered, and she's doing fantastic. It's great. So COVID has been very challenging for so many, and this last year was quite the roller coaster for many. I'm thankful that we were able to assist so many through their COVID claims, and I pray that any lingering effects dissipate and that everyone can return as normal as life as possible. Thank you. I hope you found this information on COVID educational. Thank you again for your time. I think that's it.
Thank you, Spencer.
Thank you.
Thank you. Appreciate your time today.
You bet. Thank you.
All right, so I will send out an email letting everybody know if we are able to meet at the Gardner Village in August. And like Danielle said, that will be probably August 26th, if we can get that. So I'll let everybody know. And then I have I took roll. So whoever was still on here, I will get your credits entered into the state in the next couple days, probably Monday, to be honest. And it's only adjuster credits. Sorry, we haven't been able to get the nurse case managers credits through the state. So I do apologize for that.
That they can, their nurses can do that post approval.
Okay.
Yeah, I mean, I guess it does cost $15 though, I think. But they can get the CEU credits doing a post submission, but we would just need paper indicating that this happened.
Okay, I can probably print off a certificate for all the nurses who attended and get emailed out. And does anybody have any questions for Spencer before we go, or any other questions for the Breakfast Club?
Hopefully next time we have bacon.
Yeah.
Yes, real food and face to face.
Yes,
Right?
for sure.
Perfect. Okay, let's see. I'm just checking the chat really fast. Okay, so I can email the PowerPoint out to everybody. It looks like they said that if they have the PowerPoint, you guys can submit that too for your credits. And yes, anybody who did not RSVP previous but is on today, you will get your credits. And if I don't have a adjuster number for you, when I'm entering, I will probably just email you separately to see if you have one or not, just to make sure you get on the list. So,
And we will send both PowerPoints. So don't worry, you'll get the ethics one too.
yes. And I will obviously, I'll send a link to the video because we're recording this. So I'll send everybody a link to this as well. So. Okay, I think that's it. And we will see you guys in August in person.
Fingers crossed.
Thank you. Thanks, everybody.
Hey, everybody have a great day. Thank you for joining us.
Stay safe all.
Thanks, guys.